from the Shivanand Desai Center for Digestive Disorders at Deenanath Mangeshkar Hospital. So I have with me my colleagues, our team, Dr. Harshal Gadikar, Dr. Rajendra Pujari, our fellows and everybody, our anesthesia team, Dr. Amrita Bedekar and Dr. Sagar Bandishti, and our entire team over here who is there. So we're going to demonstrating about 4 or 5 cases. So let's start off with the first case, and we'll run 2 rooms, so we'll go in tandem. So I have already introduced the scope for the first patient, and maybe Dr. Ajay or Dr. Mangesh, Ajay will give the history of the first patient. Let's go ahead.
Thank you, sir. For the first case, we have a 72-year-old male presented to us with painful jaundice, anorexia and weight loss for the past 1 month. Patient had a bilirubin of total bilirubin of 5.8 and a direct bilirubin of 4.7 with an alkaline phosphatase of 203. His ECT abdomen showed an uncinate process mass measuring about 18 into 18 mm, which was abutting the SMV. The learning objective of the present case is to demonstrate the hepatobiliary pancreatic anatomy on EUS and to perform EUS guided FNB of the uncinate process mass. Over to you, sir.
Okay. So Mahesh, are you getting the endoscopy view or the EUS view rather?
Yeah. Yes, sir.
Okay. So I have already introduced the scope, and my scope is at the gastroesophageal junction. Now what I'm going to do is I'm going to spend a little bit of 2 minutes showing you the anatomy from the station-wise anatomy. So my scope is in the neutral position just now, and I'm scanning the left lobe of the liver from the gastroesophageal junction. Can you see the left lobe of the liver with the dilated intrahepatic biliary radicals?
Yes, sir.
Maybe Harshal, we can show the marker, and we can help show that. So these are the dilated intrahepatic radicals. And now I'm using the linear endoscope UCT 180 from Olympus with the UAME2 Premier Plus machine, which hopefully will get changed to the UAME3 very soon. And now to scan from station 1, I will be rotating the scope basically clockwise to see various stations. So this is the left lobe of the liver in the neutral position, and now I start rotating clockwise until I see the porta. Now this is the porta, which we can see the portal vein and the bile duct, dilated bile duct behind that. And we can see that the bile duct is quite dilated. Maybe Harshal, you could just measure that in a moment. It's about 21 millimeters. You can see it's grossly dilated. Right. We can unfreeze and we can see. And now further rotation. Oh, sorry. Yeah, it got frozen. Yeah. Further rotation will bring us to the IVC and then to the abdominal aorta. So this is the abdominal aorta from the G junction. And now when we are doing an EUS, we should always follow the aorta at the G junction. Then in the stomach, you follow the pancreas, and in the duodenum, you again follow the aorta in the descending duodenum. That should be the principle. Now, you can see the crest of the diaphragm right in front of, right on top of the aorta over there.
Yes,
and now I will follow the aorta downwards as it enters the abdominal cavity. And now we try and look for the celiac artery, take off. Sometimes it is not dead in the midline, but here you can see that the celiac artery take off. And distal to that, you will also see the SMA very often. Yeah, you see the SMA, that's the celiac. And that is going to point you to your pancreas. So this is where your pancreas is. He's an elderly gentleman, so his pancreas looks a little bit atrophic, so we'll just blow it up a little bit. And you can see that the pancreatic duct in the center of the pancreatic tissue.
Yes, sir.
Yeah. And you can see 2 black spots over there, which are vascular structures. The one at around 1 o'clock is the splenic artery, and one which is at around 6 o'clock is the splenic vein. Now to trace the pancreas, first I trace it towards the tail. For that I have to turn my scope clockwise, and I do a gentle up movement, and I also pull back the scope if required. So this is how I'm pulling back the scope. I can see this. And as I turn, I can also start seeing the left kidney deep to the pancreas over there. I can see that. And then further rotation will bring me to the splenic hilum and to the spleen. That's the spleen. And that is the splenic hilum, and that is the tail of the pancreas. You can see at around 11 o'clock over there with the splenic hilum. And as I rotate backwards again, I can also see very often the suprarenal. That is the suprarenal over there, the bird shaped suprarenal. You can see the left adrenal gland. And now that brings us back to the neutral position on the pancreatic body. So this is how you scan the pancreatic body and tail. And now to scan the head region, the scope has to be turned anti-clockwise and pushed a little bit so that the splenic vein actually goes downwards and you start seeing the confluence. So you are seeing the confluence over there. And I have a suspicion that this patient's portal vein or the superior mesenteric vein SMV is partially thrombosed. You can see that the pancreatic duct is a little bit dilated in the head. And that is how you see the confluence over there. Now, yeah, you can put the Doppler also maybe that will show you that there is a little bit of a patchy flow over there. So that is how it is. Now, I will just move to the pyloric station or the T1 station from here. So this is how we scan from station 1. And now we can have a little bit of Buscopan and then we will introduce the scope. We will go beyond the pylorus. It's important to open up your endoscopy view because the commonest location of perforations is in the duodenum whenever they happen with your linear scope. So be careful while you pass your scope across the pylorus and D1, D2 in these patients. Very often there can be some deformity because of the tumor. So be careful. So this is scanning from the duodenal bulb where we can see the pancreatic head with the pancreatic duct in cross section over there. Yeah, over there. That's the pancreatic duct, right. That's the portal vein with the confluence. And as I torque my scope a little bit anti-clockwise, we will start seeing the bile duct as well, I'm quite sure. Not yet. Probably I have to go a little bit further. That's the portal vein. And on top of the portal vein, you should see the bile duct. Yeah, so that is probably the bile duct. Yeah, so that is the bile duct, which you can see the dilated common bile duct, which is going downwards. And toward the right is the descending duodenum with the papilla, and toward the left is the liver hilum. And you can see the portal vein behind the bile duct. So now I will pass the scope into D2, into the descending duodenum, and we can have some water over here so that we can irrigate better. Can I have some water? And in the D2, what you do is D2, D3 junction, we need to have the scope straight as we would shorten the ERCP scope. We need to have the scope straight. And the first structure that we see is the aorta, abdominal aorta, that we should try and identify. I am pulling the scope back. And that is the aorta which we can see. Maybe we can get the cursor away or a little. Yeah. Now I will pull back in the same direction. I will fill up a little bit water. And as I pull back, I can see on the right side at around 11 o'clock, I can see the ampullary region with the dilated ducts. And as I rotate the scope a little bit clockwise, I can see a mass lesion over here, which is the uncinate process. You can see the mass lesion over here very clearly. Can you see that?
Yes, sir. Yes, sir.
Mahesh?
Yes.
Yeah. So this is the mass in the uncinate. Maybe what we can do is we can use elastography and we can put elastography to confirm that it is hard. If we can switch off the cursor, then this will move. Yeah. And for elastography, it is important that your transducer is a little bit pushed against the lesion so that you get a good shear wave. And now, yeah, so you can see it's almost blue, entirely blue. So that is pretty hard. Okay, release this. Okay, so now we know that this is the area of interest, and now we will proceed with doing an FNA or an FNB to be precise. Somebody may have to hold the scope over here. Right. I'm going to put some Doppler over here just to confirm that there is no major vascular structure. I'm going to use the 22 gauge acquire needle from Boston Scientific. This is usually our preferred needle for the FNB procedures, because I think the yield that is achieved with this FNB needle is probably the best. Now, get the needle out. My needle is fixed onto the sheath. I push the sheath out first. My elevator is closed. I open the elevator and gently push the sheath out a little bit till I get a free movement. And then I fix the sheath.
Which needle are you using?
Acquire 22 gauge from Boston Scientific. Okay, we can get the Doppler off, please. Stop there. This is the area of interest. Now you can see how I am making the puncture. Just pull back the stylet. Little bit, yeah. So I will never use, very often we also don't use the stylet, but we use the stylet only to push the specimen out. So now I'm going to use
What about
the elevator
SMV
and
and
then elevator is tight.
SMV?
Yeah,
What about SMV and SMV?
yeah, I will show you that in a moment. We are running. See, we have to show 4 cases. So that's the reason I did not waste too much time, but I will try and show it to you after the first pass is over. Okay? Because the portal vein itself seems to be showing a patchy flow. Yeah. Okay. Sir? There's the needle, which you can see. I push the stylet out a little bit so that any this thing. Yeah. Now I will make 4 strokes like this. Then I will change the orientation. Again, make 4 strokes. Now you can use your up-down wheel, your elevator, and also your torque, because fanning technique is in all sides. So this is how you do the fanning technique.
Amol, how many passes would you like to do this mass?
Mahesh, I can't hear you very well. Okay. Yeah. So when we have on-site cytopathology available, we would usually do about 2 passes. And with the FNB needle, most of the times 2 passes are adequate. But sometimes when we don't have on-site cytopathology, like today, when today being late, we don't have anybody for cytopathology, we might take 1 more just to be sure. But usually it's adequate. And we would use something like a MOS, the macroscopic on-site evaluation, so that which will be necessary so that we can evaluate the specimen quality. And what I will do is I will express the specimen onto the slide. Until then, maybe if you want to go to the next room to Rajendra, you want to do that? Yeah, we can go.
One question. What about ROSE versus MOS? That is macroscopic on-site evaluation versus rapid on-site evaluation.
So when you do cytology, you need to get ROSE. But when you are getting an FNB, like we get with, the current kind of needle, like the acquire needle, using macroscopic evaluation will give you a good estimate of the sample that you have collected in your needle specimen, and that is how it works.
Sir, Mahesh, yes, sir. The process mass, if you use a 25 gauge, would it make a difference in easy accessibility?
See, and 20 gives better yield quality, but sometimes if the unfilled mass is not very, the location is very awkward, sometimes you may need to use a 5 gauge needle. Now, I don't know whether you see this, give the external camera please, and you can try and zoom this completely.
Yes,
can you see this?
Yes, sir.
So this, you see the white tissue in between the red. So that white tissue is actually the pancreatic tissue, which you can see. So this is macroscopic on-site evaluation. So this is what you can see is adequacy of the sample. I don't know how much zoom is acceptable by our camera, because we don't have our microscopic camera today because of the time. That is how it is. So we will send this for cytology. Maybe we will move to the next room. The Rajendra is ready with another case.
Yes,
so
yes,
can we have the next history for the next case?
We'll go to the next case.
पटकन नीडी कर दो अजून एक खाजगी येणार आहे आणि पेशंटला बाहेर काढ.
Pancreatitis presented with abdominal pain since 4 weeks and vomiting and fever since 1 week. CT was suggestive of pseudocyst of 14 by 10 centimeters along vessel curvature. Learning objective is to demonstrate the technique of EUS guided pseudocyst.
Okay, here we have a patient of chronic pancreatitis and is presented with a large peripancreatic collection, mostly pseudocyst, and also he has fever and abdominal pain since last 1 week. So I am going to demonstrate to you endoscopic ultrasound guided cystogastrostomy and drainage. So are you able to hear me?
Yes, sir. It's clear.
Okay. So here is the first thing which I am going to do is I am going to scan the entire area. Yes, as you can see over here, there is a large peripancreatic collection in the region of pancreatic body. I'm just going to measure it now. It is going to be around 12 centimeters by around 8 centimeters.
Can the image be shifted to the larger
You can see over here. It's 10 by almost 10 by 9 centimeters. So the contents are pretty clear, but you can see over here some debris at the base.
So can we have the EUS image as the larger one?
Can you show the EUS as a larger one? Okay.
Yes,
So this is a large collection. So before proceeding and puncturing the collection, the 3 things which I'm going to say, check it is, first thing is your puncture site should be below the GE junction, so you are not puncturing the esophagus. Second thing is you want to make sure that there are no major intervening vessels between the gastric wall and the collection. And third thing is the distance between the gastric wall and the collection. You can see over here is hardly 4 to 5 mm. So once you are sure that these 3 things are okay, then you can find a window with a clear vascular area, and then I'm going to proceed with this 19 gauge Boston Scientific needle.
How much is the solid component?
Can you just take out the flow? Okay, you can see over here the sheath has come out.
Yes.
Important thing you should not do is you should not puncture the cyst tangentially. It should be little bit perpendicular. You can see over here the needle should go not tangentially, but it should go little bit perpendicular to the collection. So this is the needle. So I am going to aspirate the fluid. Can you aspirate the fluid? Can you focus the camera over here, over the needle? This looks like turbid and cloudy, brownish fluid. So definitely looks like infected fluid. That is the reason he is having fever. Okay. So the next thing I'm going to do is I'm going to pass a guide wire through the needle.
So this is the 19 gauge needle you have used?
Yes, yes.
So we have punctured with the 90 gauge needle. Okay, now what I have done is I have passed the guide wire, and the guide wire should go deep inside the cavity, and it should have at least one loop, so that when you are exchanging the needle, it doesn't lose the track. So once I have made sure that the guide wire has gone deep inside the cavity, I am going to slowly withdraw the needle. You can see over here, I am going to exchange the needle now. So while exchanging, it is important that you maintain the steady position of your scope. At the same time, you should not lose the vision of your guide wire. So you can see over here, the guide wire is all the time.
Can we have the fluoro, sir, for this? Of the guide wire?
Okay.
How many?
So we don't use fluoro. We don't even now, henceforth, all the steps where we are going to do under ultrasound guided. We are not going to use endoscopic vision. We are going to use that vision only at the time of deployment of the stent.
Right.
So we are not able to see the loop of the guide wires.
Rahul, scope there, Albai. Hold the scope. Okay, so see over here, the wire is maintained and the steady position of the scope is also maintained. So now,
Have been practicing for the last more than 10 or 15 years, I would say, and it's never given us problems. And probably the only time when we have had problems is when we've used the fluoro. So we prefer not to use the fluoro. That is our idea. Because we think looking at 3 screens makes things difficult and leads to a lot of confusion.
so all the steps we are going to do under ultrasound guided vision. So now I am going to dilate this tract using a cystotome. It's a 6 French cystotome. I am going to mount on the wire.
What will be your cautery settings with it?
The steady position of the guide wire is very important.
Can't hear your voice. It's very low from your side. Can we get your audio, please? This is the 6 French cystotome that Rajendra is using.
Amol is asking
the cautery
what is the cautery setting?
Yeah, so cautery setting is endocut I, duration 3 and interval 3. 200.
Amol,
I am going to do one more to and fro movement that
Yeah,
to have a free passage of the cystotome.
Mukesh, you were saying something?
Yeah. I was asking, what's your opinion about 10 French cystotome?
I think that the 10 French cystotome is too bulky an instrument and it is also very blunt. Because of that, it is very difficult to actually use the 10 French cystotome, and the cautery settings are not very perfect. You usually will not get a penetration very easily if it is a thick-walled pseudocyst. So we've had a lot of problems. I don't remember the last time we used it. I think we use consistently only the 6 French cystotome for all our procedures. So that is how.
But if you are using 2 guide wires or you are putting 2 stents, then pass the guide.
Adds one more step. Now you will see that Rajendra will dilate with a balloon now.
So I am using a hurricane balloon.
He will use a hurricane balloon and he will dilate.
So all the time I'm going to maintain the wire position. Okay, now you dilate. Inflate the balloon.
Over here.
Can you have?
Yeah.
Yeah, but you can clearly see properly, sir.
Performed on EUS guidance itself. So that is very important.
So now next step is to deploy, place the stent. So now while passing a stent, it is important that this exchange should happen very fast, because once you deflate the balloon, the fluid will start oozing out from this cavity. So you need to be ready for the next step. So next step is to pass the stent inside.
Yeah, that is very important function, because once the balloon is deflated, your fluid starts draining out, and even the location and the position changes.
Everything changes.
Your scope in the stomach. So this step has to be quick.
So the other assistant has kept the stent ready now. So we are.
Stent are you going to use, Rajan?
I am going to use a Anaro stent MITech,
Yeah.
3 centimeter in length, end to end, and internal diameter of 1.8 centimeters. This is the wire. You need to maintain this vision all the time throughout the procedure. Okay.
So the MITech plumber stent is a derivation of the Nagi stent. Its distal flanges are curved inward so that the chances of traumatizing the bed of the pseudocyst or the cavity are much less with this kind of a stent. Of course, it has been our policy to also place a double pigtail stent through the metal stent to avoid the metal stent from impinging into the wall of the collection. So that is our usual policy. We'll see Rajendra doing that.
Yeah. So maintain this guide wire position well.
Amol, if the cost is not an issue, which would be your favorite stent?
So you can see the stent has gone in now.
For foot image, Yogesh, I think the Korean stents, either the plumber or the Nagi stent, are really good. And I really don't have a preference to using the Axios for a pseudocyst, because I think the Axios, the advantage is the lumen opposition, and that should be reserved for a gastrojejunostomy, for a gallbladder drainage, where lumen opposition is so much more important. We can definitely use them. It probably saves you about 5 to 7 minutes of the procedure time. But then when the stent is about 3 to 5 times more expensive, honestly, I feel it is a little bit
expensive procedure.
At least in the Indian scenario, we don't really, feel justified enough to use that stent for a pseudocyst.
So I have already passed the stent inside now. Now I am going to deploy the distal end.
How do you release the stent?
Till now I haven't used any endoscopic view or any fluoro. You can see over here, the stent distal end flange of the stent is opened up. I'm going to pull this here, and I'm going to deploy the proximal end inside the working channel of the scope. Yeah.
He's releasing, retaining the flange against the wall of the collection. That is.
So it is deployed now already. Huh?
So since the predominant it is fluid collection. So what's your take on putting DPT, one or two DPT stents?
So the stent is already deployed here. You can see over here.
Yeah, Mahesh, you were asking something?
So I was asking, since it's predominantly liquid, what is your take on putting 2 DPTs instead of the lumen opposing
Plastic
stents?
stents instead of. Okay, so see, this patient has a bit
Fever.
of fever,
The fluid is also turbid. Yeah.
Lots of solid debris inside, but these patients and the collection size is quite large, about 800 to 900 ml. So we have encountered problems when we've used plastic stents in these patients. Some of these patients have come back with fever, and then they secondarily develop some solid debris inside, which becomes a really,
And especially for the large collections. Yeah.
it's for a rapid drainage and decompression of the collection, because that actually gives us a good benefit. And of course, we have to go in 2 weeks later and pull out these stents and probably put in a double pigtail stent if we desire to have a long-term drainage through the cystogastrostomy. This patient will probably undergo an MRCP later also, and we'll again evaluate for, whether there is a disconnected duct. He also has some changes of chronic pancreatitis.
So you will probably need ERCP.
And he need a MRCP. So all that will need to be done. So that would be.
So I am deploying the DPT now. So during this also I am not going to suck any fluid, because otherwise it will interfere with your vision.
And necessarily these patients need to be intubated, because otherwise they
will aspirate. Yeah.
Which can suddenly come up into the esophagus and it can cause.
Okay.
Can aspirate.
Amol, what is your experience with hot Nagi and hot Spaxus?
Okay, the DPT has been placed now.
Now with suction of the stomach. And I think Harshal is ready in the next room. So any questions? Otherwise we'll move to the next room.
How long would you like to keep the stent?
Less than 2
We
weeks.
will call this patient within 2 weeks, after about 2 weeks with an ultrasound. If the ultrasound shows that the fluid collection has resolved, we'll put this patient up for removal of the metal stent, exchange to a plastic stent, and also an ERP at the same time. So this would be sometime between 2 to 3 weeks.
Okay.
Yeah. So we don't have an experience with hot Nagi so far. It is a good stent to use. I definitely will agree, because it will save the number of exchanges of the instrument. But again, for a fluid collection, this has become such a standard procedure that I am a little bit reluctant to change policy. This is what is more of a personal preference, I would say, in our department rather than anything else. Definitely, not a problem. I think we'll move on to the next room. Harshal is ready with another interesting case over there. So over to you, Rohan, for the history.
Coming to the third case, this is a 54-year-old lady who presented with a history of obstructive jaundice-like symptoms for the past 2 months. She's a known case of carcinoma gallbladder, status post-radical cholecystectomy 4 months back. The MRCP presently shows a type 2 hilar stricture, as we can see on the top right image. ERCP was done 1 week ago, and a biliary SEMS was placed in the right hepatic duct. Guide wire could not be negotiated into the left hepatic duct. She persisted to have fever, and repeat LFT showed persistently elevated bilirubin. So the plan now is to do a EUS guided hepatic gastrostomy for left hepatic duct drainage. That is the learning objective of this procedure.
Okay. Hi. Good evening. Mahesh, am I audible in the auditorium?
Yes, sir. Yes, sir.
Right. So as the history presented by Rohan, this is a patient with obstructive jaundice, and we have to try and drain the left system because the right has been drained with ERCP, and we could not drain the right system because the wire, it was unable to negotiate the wire. So as we know that if we are going to do hepaticogastrostomy, we need to try and target the segment 3 ducts, because they will be slightly below the GE junction. And if we come above into the esophagus, the segment 2, those are, that position is though beneficial, it is a little difficult because we cannot leave the stent into the esophageal lumen. So the best place for us to try and puncture would be just below the GE junction. That would be the segment 3 ducts. Now, if you see the screen, can you get the image, EUS image?
Mahesh?
Yes,
Do
sir.
you have the EUS image, please?
US image we can see, sir.
Yeah, I think they are getting it. Only thing is audio, we are not able to listen to them.
So what I'm trying to do now is try and see if I can get one of these ducts aligned with my path of the needle so that scope so that we can yeah, so that we can once the duct is punctured, we can start with our further procedures. So that's the needle that is coming in.
Harshal Yogeshwar, what segment are you targeting, Harshal?
Okay. Can you appreciate the needle inside the duct? I think,
Yes.
aspirate first. So we'll just aspirate quickly to make sure we get bile. Yeah. Can you focus on that? We can get there's bile in the syringe. Now you can inject and take the gram. To the fluoroscopy, please. Okay. Okay. Okay, Mahesh, can you?
Yes. Fluoroscopy.
Okay, Mahesh, can you appreciate the left duct filling up there?
Yes.
Yeah.
Okay. See, the second thing that is important, Mahesh, is to try and align the scope in the direction of the porta. That is another very important point here, because you want your wire to start going into the direction, because if your needle is facing in the other direction, it can be challenging at times to get the wire to go across into the towards the porta.
Got it, sir.
So here the other thing that you can notice is the contrast is not really going across into either the bile duct or into the right system. So this is a completely isolated system here, and we will try and drain it independently.
Which guide wire you are using?
Yeah, so we are using the Terimo 260 centimeters J-tip Terimo wire. The advantage is it's very floppy and it can be maneuvered easily. Now I have Vilas with me, who is our head technician here, and he is the past master in trying to negotiate in these kind of situations. So as you can see, we have he has managed to get the wire into the
Little bit opacified with the.
yeah. I was just yes. I was just going to say that. So there is a little bit of a opening somewhere which is allowing the contrast to go across. But for an antegrade stenting, this is going to be a very tricky situation. So I still think that hepaticogastrostomy. What do you say, Amol?
I think so, because trying to cure through the side holes of the
Stent is going to be very, very challenging. Yeah.
So where?
So yeah. So now what we are going to do, we are going to exchange gently. So my needle has come out. I'm going to lock it, and now it is important to note that the wire we are using is a 260 centimeter wire. So this is again a tricky exchange. What we need to do here is, once the wire, we have to have the fluoro in view at all times. That is the first thing. And secondly, what we need to do is, once the wire is it runs out, then as you can see, Vilas will start flushing the end of the needle with saline, so as to maintain the pressure and prevent the needle from slipping out. So that is the next important step here. And the second, similar in the same breath, what I can say is, when the endoscopist is exchanging, you need to be very careful, because if you give a jerk at the time of exchange, the whole assembly can really come out. So at the last part, you need to be very, very careful and make sure you keep holding on to the needle. So these two steps are very important, so that the position is maintained. Now, as you saw Rajendra demonstrate in the pseudocyst, we will be using the 6 French cystotome to try and go across and sort of secure the position.
Can we
of the
have
wire
EUS as the
and
main image?
pass in a more stiffer guide wire.
Any advantage of using the short wire system?
What's happening?
Can we have EUS picture big, please?
We can't really hear you very well.
Yogesh sir was asking whether the EUS picture can be enlarged.
Yogesh and Mahesh, we can't really hear you very well, so I'm unable to get the questions being asked.
Yes, sir.
So now, Harshal, you are going to exchange the Terimo.
Yeah, so first thing we are going to do is get the 6 French cystotome across. Once that is done, then we'll change for a stiffer wire.
Harshal, what's your preference? You will go for segment 2 or segment 3 ducts for hepatogastrostomy. So what is your ideal preference?
So this is, as I said before, this is segment 3. Segment 2, you will hit the esophagus. We don't want to keep our stent in the esophagus. So it is always going to be segment 3. So if you can appreciate the fluoro, you can see my cystotome is coming out. I can try and use a little bit of a current here to aid my passage.
Can we reverse it, sir? The fluoro to be enlarged now.
The good progression of cystotome over the wire.
Yeah. So I just required to use one tuck at the pottery, and my cystosome is across into the. So now what I'm going to do, we are going to change the wire. We're going to remove the Terimo, and then we are going to exchange it. So before we remove the wire altogether, Vilas has a brilliant idea. He says we'll try and see if we can get into the bile duct, because if we can, then that will make our job a little more simpler. The anchorage will be very much better if we can.
Which is the next wire he is using now?
Because we were a little encouraged because we saw some amount of contrast trickled down. Yeah.
Can you repeat the question?
Which wire?
Yogesh, can you repeat the question?
Which wire?
Which?
They exchanged the second wire.
Now we are using the
4 to 5.
We still at the Terimo only, Yogesh. We have not changed the wire because we are trying to get across the tight stricture. Once we have, we'll probably use either the Visiglide or the Jag wire.
The wire is not getting down.
So it's being a little difficult. No, we are finding it a little difficult. So I think it's okay. We will change the wire.
What would be your preference? 0.025 next or 0.03?
So now we are using the Visiglide.
You are using 0.025?
Yeah, 0.025. Yeah, 0.025 Visiglide wire. Okay. So now the next best thing we did is, as you can see, we have got the wire deep across into one of the peripheral ducts. Yeah. So that gives me a little more comfort. And now I'm going to get my cystotome out. And I'm going to ask my sister to keep the stent ready, because since we have created a track, we don't want a long time interval. before putting in a stent so that we don't actually have any leakage. So I'm going to try and push the stent directly because I think
are you using?
we are using the GeoBar, but this is from the MI Tech.
Any specific design of this stent?
So interesting thing is that it is a 50-50 stent.
Okay.
So the half the stent which is going to be inside is uncovered so that it doesn't block the peripheral draining ducts, and the other half is covered, especially the part which comes out, so that there is no leakage. Yeah. So let's see if sometimes it can be tricky to get the stent across in that position, and in that case, we may have to dilate with a hurricane balloon. So let us see.
Yeah, it is advancing nicely.
Yeah, I think it is gone.
in.
It has gone in.
Very nice.
So, so now I'll try and go as much distal, in the sense more closer to the porta as I can, because that will give me adequate length of the stent. Otherwise, what is going to happen is a little extra stent will have to be left into the stomach. But then that is not a problem, because of the uncovered stent, the chances of migration are going to be less. So yes, so Vilas is now actually releasing the stent. So we are closely following the stent, closely following the stent.
It has opened up now.
It has opened up. One minute. Okay. Okay, please continue. So we are beginning to deploy.
At what point are you going to see?
So I am now getting onto the endovision, right? Because now the endoscopic vision is going to be more important.
What is the length
Okay.
of the stent?
Keep deploying. So this marker is the covered part. Yeah? Yeah. Okay. Okay. Keep. Yeah. Okay. So do you see this?
I see.
So the covered, most important part here is that the covered portion we can see right in front of us.
Covered portion should be breaching.
Excellent.
So the covered portion is right in front of us. And so we are, and you can see the bile coming out from there. So now,
Very good. Very good.
because this is the GeoBar stent and there is really no place for me to keep any stent inside this, we leave it like this. It's going to anchor itself. And I think that would be the end of the procedure.
Great
So
job. Total
if there
length
are
of the
any
stent.
questions, we will take. Otherwise, I think if Amol is ready in the next room, so we can, I think we can move it because we would be running short of time. Thank you.
Thank
Great
you.
job, sir.
Good. Well done.
Now moving to the last case, we have 75 years old female patient who presented with metastatic hilar cholangiocarcinoma post biliary SEMS placement, now presented with persistent vomiting since 1 month. Upper GI scopy was suggestive of gastric outlet obstruction and CECT showed hilar mass infiltrating into duodenum. The learning objective of this case is to demonstrate the technique of gastrojejunostomy using hot axios. Now moving over to Dr. Amol Bapaye, sir.
Okay, Mahesh, Yogesh, am I audible, visible?
Yes, sir.
Very
Audible,
clear.
well audible.
Okay. Maybe you can just try and speak a little bit louder because we are not very clear. Your voice is not very clear. So this is a patient for a gastrojejunostomy. Are you getting the EUS image
Yeah.
and also the fluoro image?
Yeah.
It doesn't matter if you don't see my image. That's not a big deal.
You're-
You can see me a while later, but presently you need to see the EUS image in the big screen and the fluoro image in the small screen. So just let me know if you can see that. Then I will.
Yeah.
Yes, sir, we can see.
Yeah, so on the EUS image, you can see that we pass the scope beyond the pancreas and we can see the dilated bowel loop over here. And on the fluoro image, if you can appreciate, there is a nasobiliary tube that we have placed at the DJ flexure already. And we did that before actually going live because we wanted to save time. So that is passed over a guide wire as any standard with a regular gastroscope. And now we've given glucagon and buscopan to this patient. And what you can see is the paralyzed duodenal loop, the DJ flexure loop over here. And we have filled it up with saline, stained with methylene blue. And Rahul is filling up. So he's put in about 250 ml so far. And he's putting about 50 ml more. And we'll put in also some contrast to just check that. So Rahul, what are you putting just now? Contrast or saline? Okay. So after this, put contrast also. Glucagon is probably the most important, even more important than me, I guess. Because anybody can do the procedure, but you can't do it without glucagon. That is what I would say. Buscopan, it's not the best alternative. You can try with buscopan, but sometimes, the peristalsis, you will still get a little bit of peristalsis with buscopan, and that's not really very nice to feel this thing. So that is a problem. Now, usually with between 250 to 300, the loop starts filling up reasonably well, but you might need more. So it is an arbitrary figure. There is no rocket science that you put in that much only. So put in contrast now. Because I need to see which loop we want to target. So I have already loaded the stent. I'll talk about the stent in a moment. Okay, so that loop is filling up over there. And the loop is filling up distal also over there. So are you able to appreciate the loop on
Fluoro? Yes, sir.
fluoro?
Yes.
Yogesh?
Yeah.
Yeah, okay. So you can see appreciate the loop on fluoro. So most likely I'm in front of that loop. That is what I feel. Now what I will do is, I will ask Rahul to stop the contrast. Just keep flushing a little bit of saline. Now I'm going to use the 20 millimeter Axios stent over here, the hot Axios. And this is where it really becomes useful, Yogesh, because otherwise what can happen is, here you want a luminal position. So you want a one-step procedure. So you don't want any kind of a mishap happening when you are exchanging your instruments or wires. So here I will definitely try and go one step and then see how things go. Now the loop orientation is not really the best. So what I'm going to do is I'm going to move the scope around a little bit more. Okay, on.
Amol, what did you use?
And this is a combination of fluoro plus the EUS image board. Now I'm going to release the lock. Now the cautery effect that we are using is an auto cut effect 4 with a wattage of 100 watts. That is what it is.
Amol, what did you use to fill up the loops? The NBD?
Okay, so we use saline stained with methylene blue, and in the end we used about 50 ml of contrast. So that is what we have used. Okay, now Prakash, if you can focus on my hands.
You can make it big.
Now, this is not the best position which I have. I usually like to see the loop falling away so that I can get a better trajectory of passing the stent inside. But this is probably the best that I can get. Fluoro on. Okay, so I am puncturing over there. I can see that. Now I am going to activate the foot switch of the cautery and push at the same time, and hopefully we'll go across. Now this is always a little of a challenge, and you have to be very careful. At the same time, go in one stroke.
Yeah. Sorry.
Wait a minute.
Yes.
I'm going to unlock, lock this, and I'm going to release the lock over here. Now I'm going to open the first flange on, fluoro on. And now I'm going to pull this back. Can you see the stent over there? I'm going to pull this back all the way like this, and that is the beauty of the lumen opposing force of the stent. Hold this over here, Sambhaji, 1 minute, till I can lock. And now I will release the next flange, and I am going to release that inside the scope. I have released this inside the scope. Now I will open up the EUS, the endoscopy image, and now let us look, see what we've done. Elevator open. I give a little bit of air, big wheel down, and I start pushing the stent out a little bit at one time. Keep the fluoro on.
This is the most important step of entire procedure.
Yeah, I'm pushing the stent out gently, gently, gently. And there you can see the methylene blue. Can you see the methylene blue?
Yes, yes. Great, very, very clear.
So
Sir.
this is almost one-stop solution.
Okay, so now we'll get the stent out so that I can suction better. And then I can.
Amol, what's your opinion about Etoi's
You
tube?
can even try and see through the lumen of the stent and put in a little bit of contrast to see whether there is any leak. Yeah.
Amol,
Yeah, what is your question?
what do you think of Etoi's double balloon catheter? Is it really?
Double balloon.
Well, it is a good device, but unfortunately we don't have
Not
it.
available.
We've been hearing about it for the last 7-8 years. But Etoi has not shipped one to us. So unfortunately, I have no first-hand experience of using it. The only challenge with that device, which getting that device into the duodenum or into the jejunum is sometimes a big challenge because it does not go through the scope, and sometimes that needs a
reboot Zoom question mark.
What is the comfortable distance between the stomach and the jejunum when we are initially planning to put the stent?
What is the question?
Yeah.
Can you repeat the question?
The question is, when we were doing the preliminary EUS, what is the comfortable distance between the stomach and the jejunal loop?
The distance between stomach and
What is
jejunal
that?
loop is asking.
It should be as less as possible, definitely under 1 centimeter.
Okay.
How long does it take for the stent to expand to
Okay,
its full diameter?
contrast, 50 cc contrast, put it in. Now give the fluoro image. Hopefully we will not have any leak. So it's filling up the bowel, you can see that.
Yes.
And there is no leak.
Very clear.
So I think that is the proof of the pudding. We'll give this patient usually fasting overnight, and we will start them with liquids next day morning. Usually they might require some prokinetics because usually they will have some gastroparesis related to the malignancy as well as with this, but that's okay. We can usually manage that.
I'm introducing one, you introduce also.
Great case.
And that is probably the end of the procedure. So I think with that, I think Yogesh, we are we might be exactly on time, or we might be about 5 minutes delayed.
Yeah.
Where is Harshal? Yeah.
Yeah, we are almost.
Yeah.
on
So
time.
I would like to take this opportunity to thank you once again for giving us this opportunity. And if there are any questions, we will definitely be happy to take any questions before we sign off from over here.
Amol, great presentation, and all the cases
Any
are very
questions?
nice. Can you hear me, Amol? Can you hear me, Amol?
No worry. If there are any questions, that's fine.
Okay.
Yeah, we can hear you a little bit.
Yeah. Well, I was asking for GJ.
Transmit the question to us.
For GJ, what about a smaller caliber EUS, so 15 centimeters or 20? So you prefer 20 centimeters, but sometime if it is not available, then is 15 good enough, or you feel it's too small?
It can be done, but I think the wider anastomosis that we provide will give the patient a better palliation of eating and the gastric outlet obstruction. With a 15 millimeter, see, the surgeons do a TJ of 20 to 30 millimeter in size. So if you want to emulate that, you at least need the 20 millimeter stent to be able to do that. You're doing anything smaller, you're just undercutting it for no reason. From a technical standpoint, there is really no difference using a 15 versus a 20 millimeter stent. There is absolutely no difference. So why use a smaller stent when you have a larger stent that is available? That is my take on that.
Okay, Amol, we thank you and your entire team for nice demonstration, and thank you from all of us here, and hope to see you again soon.
Thank you very much, Yogesh, and have a great meeting. All the best for tomorrow and for the rest of the day today also. And see you sometime very soon. Thank you. Bye-bye.
I think with this, we come to an end of this session.